much for the very nice introduction. So it's a great honor for me to be here. It's also my second time, and also it's a great privilege to talk in front of such distinguished people. So I'm working in Acıbadem Maslak's Comprehensive Spine Center. This is, I believe, really deformity center of excellence with its state-of-the-art technology and also with their support. So I would like to acknowledge that my hospital, and thanks to them for providing me all these technologies that I will mention here. So when this study was, or this talk was given to me, I just, as with the title Contemporary Approach to Surgical Treatment, I just thought that I was in this spine business since almost 21 years. And I just thought about the developments in surgical treatment, and I said, wow, I think we have proceeded a lot. So in this talk, of course, I will not too much talk about indications, complications, and I will not make it boring for you, but I will try to give you some very brief information about what advances we have made in surgical treatment, and also I will try to show you as much case as possible from my experience. So in the beginning, I will just talk on patient-focused care philosophy. So these three things are philosophic things that we have changed in our minds as spine surgeons. By the way, I'm a strong believer of conservative treatment, in opposite to many spine surgeons in Turkey. And we have a stroke team, and also we have a brace team. Mina has visited us, and Dr. Mania also came to our center. So, of course, our first trial has always been to treat this disease or this state, this status with conservative treatment methods, and then if they fail, then we do surgery. So then I will talk about safety measures that we have currently, because those surgeries are known to be very dangerous, as you know. And then I will just talk about fast recovery things. This is also a very trendy topic, not only in spine, but also in arthroplasty surgery. And then I will just talk about the modern instrumentation area, and then our last vision philosophy. And I will briefly, that was a great talk by Dr. Rigo, so I also have some information, some new information about sagittal plane, which is the most difficult thing for us now. So in the surgery, I'm dealing with the coronal plane maybe for 1 hour, but then I try to create the sagittal plane, which takes me almost 2 hours in the surgery. So I think sagittal plane is getting more and more important. And then I will just talk about modernization of some old school techniques. And finally, I will finish with the non-fusion surgical techniques, and I will just briefly give you my experiences about vertebral body tethering and non-fusion minimal invasive surgery of scoliosis. So regarding the patient-focused care model, I think we had a lot of changes in our approach for the surgical candidate patient. Remember, the main attitude of doctors were those hierarchical doctors just dictating the surgery in terms of degrees. So if you have 40 degrees, okay, you're fine. If you have 42 degrees of deformity, okay, go to surgery. So I think this is changing. Now we are just getting patients and parents, and we're just discussing about that. I'm spending at least 20 minutes, and especially if there's a decision for surgery, I don't hesitate to spend time with the patients and parents half an hour. And then I just have my multidisciplinary team, my physiatrists, also my physical therapists, brace people, orthotists, to be involved in the decision making. And then the care, rather than dictating the care to the patient, we discuss about several different options. And then by communicating with the patient, we just decide on what to do. And our patient outcome is no longer radiographic outcome. So we are very much proud to make a 120 degree of curve to 0 degrees. We like it very much. But now we are more interested with how much does this correction really changes in the health-related quality of life of that patient. Is there a difference between correcting that curve to 0 degrees or to 40 degrees with a less dangerous operation? So finally, I think our decision making is, by the philosophy of optimal care, is a mixture of quality of life measures, evidence plus physician's experience. I think this is also very important. and also patient preferences, and then we finally we decide on what to do. For the quality of life measures, we use several different outcome questionnaires, and SRS-2 and 2 is the most common one right now, which includes pain, function, perception of self-image, mental health, and then we get a subtotal score. And also we have those informative booklets, writing everything in that, complications, expectations. So for Turkish culture, it's also something, it was also something very different. Because when I write a lot of complications in this book and give it to the patient, I had patients who gave up having a surgery. But this should be very transparent and we should discuss everything. So just an example of a patient. So this is a patient, 14-year-old, post-menarche 1 year. And she's also almost approaching the maturity, and we have discussed with the patient. She passed through the brace treatment and short treatment, but she was a non-compliant patient to both therapies. And I mean, it's only 40 degrees. She's approaching the end of maturity, so indications between 40 and 50 are to be discussed according to maturity. But we know that this is in the gray zone, so it may have some development in the future, either affecting the quality of life or not affecting that. But if you look at these questionnaires, actually her perception of image is really very bad, and I think this is also affecting her mental health. And after discussing all these things, then the surgeon has a little bit driven me to do the surgery. So I think they are also now having some rights to decide. Of course, I would never operate 20 degrees of scoliosis just due to cosmetical concerns. But this 40 degrees, you can operate or not operate. So I have discussed with the patient and then I operated. And this is the final result. And if you look at the scores, this has changed a lot. So this was a decision of all of us, including all of us. And secondly, regarding the safety measures, I'm so sorry, I got a flu, so my voice sometimes may be very bad. So regarding safety measures, the traditional approach, usually we know that surgical management is very dangerous due to abdominal bleeding, risk of very high risk of neurological injury, and even sometimes death. But right now, surgical management is, I think, safer than it was ever before because of the safety checklist that we use, and specifically designed surgical tables that help us to decrease bleeding and also to get some correction even in the beginning. So we leaving less correction maybe or less correction than it was expected to be to the surgical treatment. And neurophysiological monitoring, I think it was a revolutionary step for surgery. And then the navigation technologies that we use, and also the one of the problems in terms of safety was, it was mentioned in a talk in the morning, the fact that X-rays may cause increased risk of breast and endometrium cancer. This was not mentioned, but a paper last year in SRS from Denmark has shown that also those patients may have a higher risk of endometrium cancer. I think this is very important. And now, I'm very fortunate that I have this state-of-the-art technology, EOS and 4CT. So these are the checklists that we are using. This is specifically done for spine. So this helped a lot to prevent in-hospital mistakes for the safety of patients. And these are the sophisticated tables that we use, decreasing bleeding and giving some correction in the beginning. And neurophysiological monitoring, this is done by neurologists in our team, not by technicians. It's an early warning system. It really helps decrease nerve injuries and allow more complex surgeries to be performed. And finally, navigation technology that we have. So as you can see here, I don't know if this video plays. Let's see. Okay. So as you can see here, we were just inserting our pedicle screws relying on some landmarks. So we don't see anything. And we were just saying, okay, the intersection of this and this, let's start from here. And the rest was using your tactile sensation. So I have done thousands of screws with that. Did I have too much complication? Sometimes yes, but not too much. But right now, as you can see, we can see the spine in 3D. So here is the canal. And then we can just get the help of this navigation thing, and then we just insert our screws with almost 100% accuracy. I think this helped a lot, not for the simple cases, but for the very complex cases over 100 degrees. This was a revolutionary step to get good results that I will show you later on. And this is the EOS system. I don't know if there is any in Spain. I know that there are 3 in UK. I was that fortunate that we were able to get this one. This really helps a lot. This also helped a lot for us for our research studies. And the main issue is it's a biplanar slot, so we can get the image patient in one position, and then later on we can get this thing almost with the, especially with the ultra low dose, we can get almost 10 times less radiation. This is the same patient who got the X-ray just 1 year post-op, and 2 years post-op. She was lucky we had this, and you can see the difference between the two X-rays showing the same thing. And also, it's possible to create a 3D formation by using this machine, and this also helps us in decision making and in selection of our fusion levels, and also in restoring the for our attempts to restore the sagittal plane. So this low dose CT is another thing that we have, because we have a lot of child patients, and as you know, especially when we need in congenital scoliosis a 3D scan of the whole spine, it causes some chromosomal malformations, and it may cause some diseases. But as you can see, this is a traditional lumbar CT, this much radiation, and this is the whole spine with that machine, and with getting this with a 270 DLP. I hope all the centers, this gets cheaper and cheaper, all the centers may get this. I think this is very necessary. How about the fast recovery pathways? So fast recovery, you know, in the post-op healing in AIS, these are the obstacles that we have to keep those in the hospital, and which causes the delayed healing. ICU stay, blood transfusion, and its side effects when you get a unit of blood, so your immune system is also compromised. Drains, pain and pain medication, bowel bladder function, and final rehabilitation. So regarding that, we just tried to create a pathway, and finally, after several revisions, we got it. Actually, the first one was done in collaboration with Alfred Dupont Institute in the United States. So this is a collaborative study, and then we just get that, and we applied the first one. And this is for those children who are over 40 kilograms and less than 40 kilograms, and this is for over 40 kilograms. And then we have created this pathway, and after the first experience and completion of adaptation, the pathway was tailored. Because the problem was, you know, when the Americans said, okay, you should do this, when I was telling this to our anesthesiologist, for example, you should give intravenous continuous morphine, she was saying, no, what the hell, I cannot give continuous infusion. So we had those cultural barriers, and you have to adapt these pathways according to your culture and the level of your other people, like anesthesiologists or ICU people. And then we have done a retrospective study. This was the one that I was applying routinely in my patients before switching to adapted pathway, and then this is the tailored pathway. And at the end of the day, maybe I can summarize this here with this table. We had, in 3 years, we had a surgical blood loss, which was decreased from almost 940 cc's to 294 cc's. We started almost using no drains for AIS patients. These are only for adults idiopathic scoliosis patients. And then the ICU stay was routine for all patients, but at the end of the pathway, only 8%. And the blood transfusion, we were giving 1 unit of blood to all patients before, but now we are giving no bloods, almost no bloods. And the first evacuation time decreased, and the hospitalization time decreased from 5.2 days to 3.7 days. So we are now working on to discharge. Actually, I don't like the discharge term, so making it faster and discharging those patients maybe in 2 days. So I remember 10 years ago, we were keeping them in hospital 10 days, and we were always preparing at this 4 or 5 units of bloods. I think this is a big change. So coming to the modern instrumentation, and this has been mentioned in the warning, especially the invention of those pedicle screws have changed a lot in our correction rates and also early rehabilitation, so we don't use any post-operative bracing for those patients, so we have very secure instrumentation, and also they can have early return to daily activities. I just would like to mention selective fusion. This is passionate for me, so I always, when I get the patient, I don't like fusion. Fusion is something like, as an orthopedic surgeon, like amputation for me. So I always hated fusion. But sometimes fusion is, of course, many of the times fusion is life-saving. But the philosophy always I kept, which is coming from the early years actually, which is coming from Minneapolis, and which was made more possible by the modern instrumentation, is preserving, especially the lumbar motion. So here is a case having a 62 degrees to 51 degrees of two curves. So my plan was only to do the main curve, thoracic curve, and then I didn't touch the lumbar curve. And by getting two, so you don't have to correct it to 0 degrees. So by getting two balanced curves, as you can see, especially this is for mature patient, adolescent patient, I know that there will be no progression from here. And you can see also in the clinical exam, we get a very nice appearance result. In another patient, 52 to 42 degrees. For a lumbar spine, 42 degrees, it should be operated. But what I did was, again, to balance and similar magnitude curves. And these are the X-rays, clinical photos, before and after the surgery. So you can see we can have still, despite not touching to the lumbar curve, we still have some good correction. Is it possible for the lumbar curves? Yes, it is possible. So you see there are two curves, almost similar degrees. And then I have done a selective fusion for this curve and a full fusion for this one. But with the selective fusion, as you can see, I have some residual thoracic curve, but both patients' quality of life are similar. So you don't have to operate everything. That's the reason actually why we classify those curves structural and non-structural. But these are, of course, the curves untouched are more than 25 degrees. So how about the neglected three-dimensional scoliosis? That was a great talk in the morning. So one of the problems that we always neglect, actually we don't see a problem, was, we just correct those patients in the coronal plane and we try to correct their hump. But in the sagittal plane, we were not very much interested with that. We were not focusing on that. Also, patients were not focusing on that. In fact, if you make patient more hypokyphotic, then they like it because then they gain more length. So they like it very much. But then we have just focused on this in recent years. What are the pulmonary functions when you cannot create the kyphosis? And also, we know that when we don't have the ideal sagittal plane, we use a lot of compensation mechanisms. So if those children, as Dr. Rigo has mentioned, most of them have kyphotic cervical spine. And then they try to compensate all these loss in the thoracic curve by increasing their tilt, pelvic tilt, and by kyphosing their cervical spine. In the short term, it's not a big problem, but in the long term, when they come to 40s and 50s, I'm sure that it will be a big problem. And when they get their discs degenerated, then they will not have any more compensation mechanisms that they can survive till the end of their lives. So Dr. Rigo has mentioned about that. I think this has changed a lot of things in our understanding of sagittal plane. Now, when I talk with the arthroplasty surgeons, hip arthroplasty surgeons, you're not operating the pelvis, you're operating the spinal column, because pelvis is definitely the part of, one part of, or the continuation of the spinal column. I won't mention about this pelvic instance and the other parameters this was mentioned, but we know that pelvic instance actually is the signature of us, okay? So we use this information also for the degenerative patients. And then pelvic instance is the signature of us. It is changing up to the maturity, end of maturity, up to age 16, 17 years, and then it's a constant and it's staying like that during the whole life. And we know that pelvic instance is forming the sacral slope is forming the lumbar lordosis, and then lumbar lordosis, the thoracic kyphosis is shaped according to an harmony with lumbar lordosis and then the cervical lordosis. Now we know that very well. It's a French idea. French people are very good in that. Madame Dupel and Jean Dubisset and Rosoli, these are really big guys. And then once Dr. Dubisset has defined this pelvic vertebra, and also he has defined this cones of economy. That means, so this is the compensation limits that we can do our daily activities without exerting too much energy. Okay, so a person, in order to do daily activities, should stay in this cones of economy. If she is out, then she or he will be in trouble. And we also know that in order not to go out of cones, we have a lot of compensations mechanisms, and these all mechanisms start with the within the spine. So we have rectolisthesis to restore our lordosis, sometimes spondylolisthesis, and then this is followed. If you lose our lordosis, then we compensate it by hypokyphosing our thoracic kyphosis, and then this goes up to cervical spine. And when spine is finished, then we have our pelvis, and we begin to tilt our pelvis just to stay erect. And when this is finished, and then we use our knees to stand straight. So these relations are really very important. So these are the types, but these types I really am very respectful. But the problem with all the French theories is that they are very complex. So we don't understand, how to use this in our practice. So how can I use this in my practice? How much kyphosis should I give for a type 1 pain? So that's the problem. And one of the problems is that what we are doing. So when we have a scoliosis patient, we bend the rod, okay, straight in the coronal plane, but we should have some curvature in the sagittal plane. And then we say, okay, the kyphosis should be between 20 degrees to 55 degrees, and let's make it 45 degrees. This is the average. And then we bend it to 45 degrees. And we try to make every scoliosis patient into 45 degrees. But this is not reality, because our kyphosis magnitudes are all different and shaped in accordance with our pelvic instance. Okay. So by this idea, and also we were not very happy with the shapes, and also there is some American formulas. Americans are very pragmatic, so they said, okay, PI minus lumbar lordosis is this, so you have to make this. But all of them, including Rizzoli shapes, are made on population averages. But population average doesn't work for individual patients. So we thought that we should specialize this. And what we have done, and also we should define this mathematical formula for this corners of economy. And then we said that this is, who are we? We are European Spine Study Group, including also one center from Barcelona, and I'm the co-author with Ferran Pellice from Spain in the establishment of this group, and we are now 7 centers and putting all patients, adult spinal deformity patients in a database, and we have now more than 1,000 patients almost in our database, and we have a sister group in the United States, and with their cases now we have over 1,600 patients, where we can work on sagittal plane and everything, and predictive models by using machine learning and all these sophisticated things. So we think that to describe the corners of economy, and as everything is related with the pelvic incidence, what we do is from the normative studies, there are a lot of normative studies, we just calculate with this formula, which was driven by a regression analysis, the pelvic instance, according to that pelvic instance, the sacral slope of that specific patient, okay? And once we calculate the sacral slope, then as this should be also proportional to lumbar lordosis, and then this gives us the lumbar lordosis, and then we calculate the kyphosis, and finally, we also have to see the balance of the patient. We don't use SVA anymore, because SVA, this vertical axis, is very much affected by the knees, by the positioning of the patient, and also it's a numerical value. So you have to, it may be affected with the magnification. And we use this formula. You can find this paper, it's very complicated, and I don't have time to work on that. And also this is relative lumbar lordosis, again, calculated according to pelvic instance of that patient. And also the distribution of lordosis is very important. And the distribution of lordosis should be, 2/3 of that should be from the lower lumbar arc. And after all these calculations, as you can see here, we calculate a gap score, and then here's the chart. So when we do our preoperative planning, we have some simulators now that we have created. So the patient should definitely stay in this aligned. If she goes back, then it's not good, and she may even go to positive sagittal balance. So it may be negative sagittal balance and positive sagittal balance. Here is a scoring system. These are too much, and also these are correlated with the health-related quality of life. So when we get more negative sagittal balance, we have more pain. But finally, how we interpret this to scoliosis, I will show you just 2 samples. So this is a patient, 12-year-old female, and probably 50 degrees or something like that. But if you look at the sagittal plane, she has a 21 degrees of kyphosis. Now, is it good? Because kyphosis, we believe that should be 20 and 55 degrees. But this is also morphologic kyphosis. How do you say that, Dr. Rigo? This is
geometrical.
Geometrical, okay. So this is not the real kyphosis. So this patient probably have less kyphosis than this. But what happens? Because of this kyphosis, she has to, less kyphosis, she has to create more kyphosis. And how does she do that? You see the cervical kyphosis. So she tried to create more kyphosis by using her cervical spine. And if she stays like this for many, many years, then she will probably have some cervical spine sagittal problems. So this is our chart in order to make her align. And according to her pelvic incidence, which was 59 degrees, this patient should have a 31 degrees of kyphosis. And now this is our focus, and this is how we will bend the rod. So we print this, and then we bend the rod exactly according to this during the surgery. And then this is the result that we got. We were able to get 30 degrees of kyphosis, and you see how the cervical kyphosis has been corrected. Okay. Now this is another patient. This is more interesting. She has a 45 degrees of kyphosis. And this is a thoracolumbar curve. And in our surgical decision making, before using this gap, I would say, okay, we can operate only this because it's only 27 degrees, so we can make a surgery T9 to L3. But she is a little bit kyphotic, 45. This is too much. Maybe in order to prevent more kyphosis or junctional kyphosis, which will appear after the surgery, I have to go to T2. This was our understanding. And when we put it into gap, so she has a very high pelvic incidence, 64 degrees. And pelvic incidence may be as high as to 80s to 90 degrees, okay? So actually she has hypokyphotic, and her need is almost 56 degrees, okay? And in order to get this, we use our simulator, and then we plan our surgery again. We don't go up, T9, L3. This is the thing that I will bend. I would never bend this like this, and when my junior fellow gave me this rod, I said, are you kidding? I cannot use this. I have to have more lordosis here. But if you look at the result, now she has a 54 degree of kyphosis, and you see the cervical kyphosis has been corrected. This is something I don't think that any other center is using the gap and taking care of this, but I think we give more importance, and it was really good to hear Dr. Rigo's talk that it is also important for you. Maybe you can use also this gap for your conservative treatment in the future. So how about the 3D life-saving surgeries? This was a great help, actually a gift of neuromonitoring for us. So we use this for very rigid severe curves, previous diffuse fixed spinal deformities, and these cases are usually the cases that we were calling as inoperable cases. So we cannot operate you. Sorry, this is too late. Now we don't have this. With this technology and with this understanding of spinal osteotomies, and very recently by using a 3D printing anatomy of the whole spine and playing it preoperatively and getting it during the surgery nearby us and playing on that, we are doing some really crazy surgeries. Osteotomy means resection of some bone from the spinal column. This was previously done both from an anterior and posterior surgery, but now we are able to do this all from posterior, and we can resect only one facet. We can resect both facets. We can resect all the posterior elements of one vertebra with somebody. We can resect, whole body. We can resect the whole body, two bodies, so all from posteriorly and by protecting the spinal cord. And here are some samples. This is actually the easy one, 82 degrees of curve. So we have cut only the facet joints in this patient, chevron osteotomy or type 1, type 2 osteotomies, and we get this correction. This is a rigid adult deformity. She was happy, she refused having a surgery, but at age 58, she had a lot of pain, and it was a very rigid deformity in the bending not correctly. And we have done several posterior osteotomies in this patient and got this correction both radiographically. This is a more severe curve, but this is a syndromic or an idiopathic sort of curve. So it is 126 degrees, but with some release and posterior osteotomies, it may be quite flexible during the surgery. And as you can see, we got a very nice correction both in the sagittal plane and the coronal plane. This is a curve in the thoracolumbar spine, but it also has a very rigid kyphotic deformity. So we had to cut the posterior elements and some of the vertebral body here in this patient. And this is a patient who was operated many years ago when only Harrington instrumentation was available in Turkey. But later on, when this patient came to mid-ages, she had this 78 degrees of curve, which was very unpleasant for her. Also, she was not married. And this is her sagittal plane, but her main problem was the flat back, which we see most of the time after Harrington instrumentation surgeries. I'm sure you have also these surgeries, which was done by our professors many years ago. So as you see, it's very rigid because this is all fused, and there are some degenerative changes and radiculopathy here. So what we have done for this patient was also doing some simple osteotomies. We didn't try to get 0 degrees, but we got a nice correction both in the coronal plane and in the sagittal plane, and the patient was really very happy. And nowadays we see a lot of degenerative spine patients with spinal stenosis. And most of the story is they start with 1 level fusion, and then the second level, 2 years of another honeymoon period, and then another level, and then another level. You see this scenario several times. And this is unfortunately operated due to some spinal stenosis, and then the instrumentation was lengthened because of the junctional kyphosis. And then this patient came in this position. So everything is fused there. So I cannot do any release procedure, soft tissue release. I have to do an osteotomy. And as you see, nothing is in the green corridor, in the gap score. Everything, she is very malaligned sagittally. And this is what our simulation gives us. And it says that you have to do 2 osteotomies in L4 and 1 in L1 to get everything aligned in the green corridor. And this is what we have done for this patient, as you can see.
Wow.
And she is really very happy. The gap score is now 1. And if you look at the Oswester scores, she had improved from 80 to 13. So she was the happiest woman at 2 years. So sometimes in the pediatric patients also, this is a patient with congenital kyphosis, and this poor girl was operated 6 times before, but all failed, as you can see the broken rod here. So the only way is to do a limited, because if I do a whole fusion, it's a problem. A limited osteotomy for this fusion for this patient. Actually, I tried to stay in the already fused area and not to try to touch the other parts. And this is the result. By doing an osteotomy, I resected the apical vertebra all from posterior and put a cage instead of that. And these are the clinical improvements in that patient. This is a different kind of syndromic child. And her main feature of her syndrome is osteoporosis and also some malformation of the vertebral body. The only way, it's very rigid, the only way I can correct this is so there are some pressures on the spinal cord to resect this part of the spine and then to correct him. And I had to use cement augmented screws as the bone was very weak in this patient, and we got this much of correction in this sagittal plane. This is a patient, I believe, came to me from this country. And she had a neurofibromatosis type 1. She had a, in neurofibromatosis, the curves are very rigid and very short. 80 degrees and 130, 70 degrees of kyphosis, you see. I have to resect this T9 and T10, all from posterior to make this surgery, but also she has some neurofibromas in the spinal canal. This was really a challenging osteotomy for me. And then, as you see, there is a huge compression on the spinal cord, and she had some myelopathy signs. So these are the clinical photos with Caffeole signs. And then we have done this surgery for this patient, as you can see, with the use of osteotomy. And again, you see she had a nice improvement in the sagittal plane. And I resected the apical vertebra and I put a cage in them to lengthen the spinal column. And these are the postoperative clinical views. I have to tell you that in these surgeries, especially this complex, and I will show you 2 more complex surgeries, there is always a change in the neuromonitoring. So if I would do these surgeries with wake-up tests, most of those patients would get paraplegia. But when I get that warning in the, with the neuromonitoring, and I also have intraoperative CT, so I just see where the compression of the spinal cord coming from, and then I handle that, and I get everything, all the neuromonitoring signs come back. So without that, it would be impossible. This is a 24-year-old female. She was diagnosed with scoliosis at age 7. As you can see, she had a very minimal fusion surgery here, but she developed a huge deformity in the follow-ups, 2009, 2011. Her first vital capacity is decreasing, as you can see here, 2014, and this is 2015, and she came with 145 degrees of curve here in a fused spine, and 138 degrees of kyphosis here. And as it's fused, they were not flexible, and this is the deformity. You can see this is the second most difficult curve type. We name it as omega because, as you see, this is like an omega sign. Okay, so and it's all fused, and as you see, the vertebral bodies are not that good in shape, and this is the pulmonary function, and the questionnaires, clinical photos, And finally, I have this thing. So the only way to correct this is to resect the apical vertebra and then get a correction. And this is our day of planning. And I will cut 3 vertebral bodies here. And this is what I have done and what I got after the surgery in the coronal plane. She is balanced. And also in the sagittal plane, she has a nice correction. And she, if you look at her total score, she has a very nice correction. But I think the most important finding that or benefit of this patient, when a patient has a curve like this, she had a huge improvement in her lung capacity. This was something that I didn't believe before, because these are congenital. The lung is shaped during the growth, so I would think that we would have no improvement. But when you open a good chest cavity and when you open the abdomen and allow the diaphragm to move more, I think they are getting improved. And finally, for this is the most complex one, which we named as gamma deformity. It looks like an innocent curve in a 20-something years old guy, 120 degrees, 126 degrees, very rigid. And here are the clinical photos. But actually, this deformity is a transposition of the vertebral bodies. So as you can see here, maybe I have a better view. As you can see here, the spinal column is coming here, going up, and then coming again here. So there is a huge translation, and it's a very dangerous surgery to bring this under this after resecting all these things. So, and you can see all the T67, they constitute only one big vertebra at the apex, so I have to remove all of them. And for this one, I definitely need a 3D printing of this deformity. This is what I got. This was staying on my desk 3 months, so I was playing. No way, give up the surgery. I was playing, no way, give up the surgery. By the way, the patient was coming to me, please operate. And then I decided to operate, and after resecting and simulating the operation and getting this in the OR with me, so this really helped us. And the lung volume is less than 1, forced vital capacity is 34%, that subtotal score. And we named this as a gamma deformity. So, and what I have done for this surgery is surgical planning. So I have resected, you see the cage here, and I did this fusion in the coronal plane, and also in the sagittal plane I had a very nice correction compared to this. And you see the length increase in this patient. So he was really very happy. And again, for this patient also, I think the most significant improvement was in the lung capacity. So this was again a life-saving surgery. I'm naming these. So otherwise 60 degree, 70 degree curves, you may operate or not operate, but these are really life-saving surgeries. So how about the modernization of old school techniques? Hollow gravity traction is something which was really very helpful for us. And because it was increasing the flexibility in stiff curves, it was helping us increasing the flexibility in very stiff curves, so making to correct it easier. And also it was helping us, especially for the children with very poor lung pulmonary functions, increasing lung capacity. It was improving our feeding, but the main disadvantage was we had to put the patient in the bed for 3 months, and we had to do a hollow traction to make double traction from head and from the femur. We had to do a femoral traction, which was an invasive thing. And also it was less effective as the patient was lying. But with a slight improvement, we made it functional for us. This is a pterygium syndrome with a very rigid scoliosis and kyphosis. I don't know if you have ever treated pterygium syndrome, but they are really very stiff and they don't move. So this patient unfortunately had some growth instrumentations before, but they were all dislodged and they didn't work. So we put this patient into the hollow traction. And this is our modification. So we make the hollow traction and ambulatory traction. Oops, sorry. So he's happy, he's at home. So he is not hospitalized. And we can do with this home traction. So his parents, when he has some problem due to traction, just push a button and then everything is released. So this was something that we were able to use. So As you can see with the hollow traction, we were able to soften this curve a little bit, bring it to 49 degrees in the coronal plane and 59 degrees in the sagittal plane. And then we have done the magnetic rod instrumentation system for this patient, and we were able to control the curve. And this was after the magnetic instrumentation. As you can see, he also has a lot clinical improvement compared to before. Now it's been 4 years, and we have changed this magnetic rod because it ended, and he's still having a good treatment right now. This is another patient who had a severe congenital scoliosis in the lumbar spine. Also, she had severe transposition of the big arteries and congenital cardiac disease. So maybe I would be able to correct this with an osteotomy, but after the osteotomy, having the balance would be really very difficult, and to stop it somewhere in the lower lumbar spine would be very difficult. And I had to shorten the surgery. So my decision, and you can see the clinical photos of this patient, and my decision, and here is the 3D CT, to put her into hollow traction. So this is again an ambulatory hollow traction that we have done. So she is now at home, walking the whole day, exercising, dancing. And this hollow traction, of course, ambulatory hollow traction is more effective than the traditional one. So we were able to get some correction from 131 degrees to 74 degrees, as you can see in the coronal plane, and from 63 degrees to 40 degrees in the sagittal plane. And finally, and you can see the improved also clinically here. We did the traction for 7 weeks for this particular patient. And then we did the surgery, we did an osteotomy. You can see the cage again here. And we got this nice correction in the balanced spine, both in the coronal plane, and also you can see the clinical photos of this patient. So my final topic, I hope it's not very boring for you, I'm going a little bit faster. My final topic is non-fusion surgical techniques. So we use this especially in early onset scoliosis, because we know that if we do early fusion, then we will be blocking the longitudinal growth, and also we will be interfering with the lung function. So especially before age 8, it's very dangerous to do any fusion, as the alveoli development in the lungs occurs until age 8. And the chest development is until age 14, 15. Only 50% of the chest is developed until age 11. And to have one patient to have a good quality of life, the chest length should be over 18 centimeters, and the forced vital capacity should be more than 50%. So because of that reason, rather than, this was also mentioned by Stanko in the morning, so we were doing these traditional drawing rods. So we were just putting screws here, screws there, and then we were lengthening this. So this is a patient that I got in 3 years. So as we were preserving the whole thoracic spine, this patient was continuing to grow. But the problem with this instrumentation was we have to lengthen this every 6 months. So from age 3 to age 10, let's say, 7 years, this patient should have 14 operations. And we have seen that this was not really very good and causing post-traumatic distress syndrome both in the families and in the children. So this is one of my patients, and also we were having a lot of problems, hook dislocations. So we were doing some unexpected surgeries as well on top of these 6-month surgeries. And this patient, I was able to preserve the motion and also growth until age 10. But at age 10, I had to do this surgery, and she benefited that surgery. But finally, we have these magnetically controlled gravity rods that was mentioned in the morning. And how we use this, this was my first case. I have been doing this since 2010, so I have a quite large series and experience with this. This was my first patient, congenital scoliosis, 58 degrees. This patient has a bar here and several heavy vertebrae on the other side. So this is a progressive curve. At that time, I found the solution actually using the Hütter-Woltmann rule, which is an orthopedic rule, and I use in the vertebral tethering right now. So I just compress the convex side by putting some percutaneous pellicle screws without doing any fusion, and I try to lengthen on the concave side. So this is followed until age 10, surgeries every 6 months. But then at age 10, I changed this rod to a magnetic rod, and also later on, 1 year after, I just removed the screws and I tried to lengthen both of them. So the patient comes to the clinic, so it takes you 2 minutes to lengthen it, and we invite those patients every 2 or 3 months, and we are lucky this is reimbursed by the government of Turkey, and I think this is a very life-saving surgery. So this patient came to age 14, and then we measured the chest height at that time to 25 centimeters, and forced vital capacity was 65%. So I did this surgery, and then from age 5 to age 14, we were able to control the curve and then finally fuse it with a good lung function. And this is another patient who had a Wachtel syndrome. He came to me at age 2, and the main curve was actually a congenital curve due to a T5 heavy vertebra. And then there was a compensatory curve, like an idiopathic curve below. So I did the surgery. First I handled the main curve, and for this 58 degree of curve, I casted the patient, and then we put him in brace. So we bought some time, as you see, 79 still brace, and at the 83 degrees, then he was 4 years old. We decided to do the magnetic rod instrumentation, and we did it. And you see, at 6 years old, until 6 years old, we did lengthenings. And then at 6 years, we had to change the rod because you can lengthen only 4 centimeters from each rod. We changed the rods. And finally, this is 4 years after surgery, the sagittal plate, we changed the rod again. And then now he is 7 years old. So we got him 2 years old like this. In 7 years, we were able to preserve the lung functions at least and growth at least for 5 years, and we are still going on with this. And our final topic. Can you just drink a water for this? This will be maybe interesting. So this surgeon's dream, especially my dream, was to handle all these problems by doing a non-fusion surgery. And also, as these are big surgeries, although after the fast track recovery protocols, we have maybe less difficult surgeries for patients, but anything that we can do minimally invasive would be great for these patients. And then we started, after some animal studies, one of my friends, colleagues, started doing this in the United States, and after following his cases, I have been the first guy in Europe who has done this surgery 4 years ago. So this is actually a minimally invasive approach, and the idea is, again, we just put screws minimally invasively from the convex side, and then we just connect them with a tether, and when we the band with a band, and when we tether the band, we do some compression on the convex side, which slows down the growth at the convex side, but also it creates a destruction on the concave side. So as you know, concave side, the destruction makes the growth faster. So this is a very basic rule, Hütter-Volkmann rule. I'm sure you know. And the main indications right now in our hands. We are examining the indications right now, but the main indications, it works best for children between 10 and 14 years, premenarche, still having a growth potential, Richter 0.2 or Sanders 1.4, and for thoracic curve 60, I've done a 70 degrees, it works also for a 70 degree right now, and it should be flexible, and the patient should not be hyperkyphotic, which is a very rare thing that we can see in AIS, and the rib hump should be around 20 degrees. So this is our surgery. So we have 6 holes, and the patient lies on the side. And as you can see, thoracoscopically, we open the pleura, and then again, thoracoscopically, we just insert, we open the hole for the screw, and then we insert our screw. You see, I do it without seeing from the monitor. This is a video-assisted surgery. And after completion of the screws, what we do is we just put the tether. As you see, this is like a bent polypropylene something. And then once I'm tethering this with a distractor, my colleague is just locking it, the rope inside too. And finally, we just check the chest, and once we are satisfied with the correction, then we finish the surgery. There were several studies, actually, surgeons are working on that since many, many years, but it has been possible since 4 or 5 years. And so I have recently presented my first case series. I think this is the European largest case series. There are some German surgeons, I think, doing that. Maybe there is one guy also in Spain, I'm not sure, started doing that.
Arito.
Yeah, Arito, yeah. So So we have presented first 12 patients with more than 1 year follow-up, and then here are our results. So in the beginning, we got a 52% of correction. We don't get the full correction because we allow spontaneous correction. Otherwise, if we get full correction, then the curve turns to the other side. And then we have a spontaneous correction in these first 12 cases. And mean correction in over 18 months was 81%. And you see there is a correction. This green line is the average. There is a huge correction in the beginning, first erect. And then gradually there is a spontaneous correction until the end of the surgery. And for the compensatory curve, for the curves in the lumbar spine, I don't operate any curve flexible and less than 40 degrees. So we had 43% correction spontaneously, and then additional 7% correction, and as a total 72% correction in patients who have at least 18 months of follow-up. And in terms of hump, also we had 52% correction. And for those patients who have more than 18 months of follow-up, the mean hump was only 5 degrees. So here are some samples of my patients. This was my first patient, 37 degrees. So 6 weeks, it was 19 degrees. 1 year, 13 degrees, 7 degrees, and also you see the spontaneous correction. And here are the SRS scores of this particular patient. And here's her video. There is not yet any study showing that it provides or it doesn't block the motion in spine, but from my observation of my patients, I think it's allowing motion, especially compared to the fusion. So this is another patient, as you can see, 46 degrees of thoracic curve. We have operated only the thoracic curve, 6 weeks, 6 months, and at the end of 2 years, this is only 14 degrees, and the lumbar curve is only 12 degrees. And here are the clinical results at the end of 2 years. This is another patient having a 60 degree of curve. In the first operation, around 30 degrees, and in 1 year, it came to 19 degrees. And here are the clinical photos. Another patient, 10-year-old female, 21 degrees, 13 degrees, now 1 degree, and this patient has a growth potential. So probably this will turn to the other side, and this is a complication of this surgery. But the solution seems to be quite easy right now, but another operation. So we just go back, and then we cut the rope or the band, and we solve this problem in that way. I have not yet any patients with overcorrection, but I think it's coming. So in terms of kyphosis, it looks like we have a nice correction. Also in kyphosis, and recovery period is amazing. So they say 3.5 days, and in this series, return to school is only 11 days. And there are even patients who go back now, not in this series, but in recent patients in 3 days. And we had a nice correction. So in terms of complications, we may have atelectasia. These are our complications, non-neurological infections, and we have one overcorrection candidate that I have shown, now 2 of them actually. So if you look at the literature, there are only 2 papers about this. These are all Schreiner's hospital papers. And overcorrection seems to be 9.4%, worsening of deformity in 3%, and tether failure. These are the cases of Amir Samdani. He allowed me to show that. This is an, as you see, worsening of the deformity, and this is an overcorrection. So at this stage, they went back and just cut the ropes. And now we started doing also double tethers with a minimal invasive lumbar incision. We are able to go to lumbar spine. It's a 3 centimeter incision. And then we do the double tether, especially for those curves, lumbar curves over 40 degrees. And you can see a nice result in 1 year in this patient. So it looks like it's a very promising surgery, but we have to wait definitely for the long-term follow-up results. And we also are working a lot on that, especially now our new focus is prediction of growth, because this is based on that. And we are not, unfortunately, very good in prediction growth. I should tell you that research sign, maturity, tender signs, they don't work solely. And I find especially sender sign more useful, but I think it's a mixture of that. So this is a problem, and I think this has provoked this technique has provoked these works on growth potential. So compare similar curves, this compared to this, I would definitely prefer this, and it looks like our future surgical technique for idiopathic scoliosis. So in summary, thank you for your patience. Scoliosis surgery, I think, is no longer a pure magnitude-driven, degree-driven surgery. So decision making, it should be as a shared decision with the whole team, and also including the patients and the parents. It's much safer. We have now faster recovery, and our philosophy is always as short fusion as possible. All techniques still work in a modernized fashion. Sagittal plane is better understood and should definitely be taken into consideration. And life-saving, technically challenging surgeries are now possible. We have very few inoperable patients now in our practice, but I think finally the dream is coming true. Hopefully we will have minimally invasive non-fusion surgery in our practices. Thank you very much for listening. Yeah.
What is the purpose of the cage?
Why we use cage when we do the osteotomy? Okay. There are several reasons for that. First of all, when you resect a huge segment like 3 vertebrae, if you shorten it too much, then the dura is buckling. Okay, and then the spinal cord is under compression there, and then we may have neurological deficit. So it's one, to prevent that. And secondly, when we put a cage, it also provides us some biomechanical advantage for fusion. It is more secure. And thirdly, we don't want to shorten the spinal column too much because it may also interfere with the lung function. So we want to preserve and in fact lengthen the anterior column and shorten the posterior column. So these are the reasons why we use cage.
Thank you. Marvelous presentation. Thank you very much.
Thank you.
We learned a lot. A question is, do you have adenome also in the tether technique or not? Adenome phenomenon.
Adenome phenomenon. Yeah. Well, I didn't have any yet. So actually, it is a big question now. We don't know if we have to apply the same rules in selecting our fusion levels as it was in fusion. But right now, what we do is we usually go from upper end vertebra to lower end vertebra. Sometimes, if the lumbar curve is too severe, I go to one below. But adenome seems not to be a big problem. In opposite, overcorrection seems to be the main problem for this. But I am again very selective also for this, and I try to not to include lumbar spine. And one of the other reasons from the American experience, I am very lucky because I learned a lot from Schreiner's experience. So I asked my cases, so they had a lot of complications, so they tell me don't do this, and I don't do that. So I learned from their experiences. But lumbar spine's behavior is much different than thoracic spine, and lumbar spine's growth is less predictable compared to thoracic spine. And so we need, I think, more information about that. So I hesitate to do lumbar spine surgeries, although I may have some adenome, especially the curve that I haven't instrumented. So I think that I have to handle that problem if I see any adenome for the next time.
Thank you. And second question related to that, yeah. Did you use tether also for any proximal therapy?
No, technically we are able to do that up to T5. But again, another thing, we have to learn a lot from a growing spine's behavior compared to a fused spine. I have the feeling right now, I have to show it with a study, also the upper thoracic spine is coming back, when you have a slow gradual correction. This is very interesting. So there were patients, I talked with the patients, you have upper thoracic curve over 40 degrees, which is not bending less than 25 degrees. So this is a quite structural curve, and it may, I may go up, maybe do a posterior surgery later on, and they say, okay, we accept that. But in my experiences, I have never had an increasing or adenome in the thoracic curve. So it's not possible right now with the technology we have. Maybe you can do open, but it's too much surgery.
first of all, fantastic presentation. And I just wanted to ask you about your opinion about neuromuscular scoliosis. When to operate and what do you take into consideration? Thank you.
Yeah. Well, to very briefly answer this question, in neuromuscular patients, I think patient education is one of the most important things, because why we operate them is actually most of the time, of course, to lengthen their survival time and to prevent lung problems and feeding problems, etc., but also mainly for the quality of life of caregivers. Okay, because it's very difficult to handle a neuromuscular spine, when the patients had a lot of deformity, also for the caregivers. And what is different than this is we do longer fusions in the neuromuscular patients. We still avoid to go to pelvis, but especially if it's a progressive neuromuscular spine or a spastic one, we usually go to pelvis. So these are differences, I think. That's it I can say.
Do you have information about what happening through the pregnancy and delivery for that young girl?
After surgery?
Mm-hmm.
Well, I don't think, there are not too many papers on that, but scoliosis patients can give a normal delivery. But in Turkey, now there are strict regulations for cesarean section. I don't know how it is here, but they find scoliosis operation a reason for having a cesarean section, but I don't think that's a big problem. And there's another belief that pregnancy may cause an increase, especially in the non-fused or conservative treated or for the curves under follow-up. And there are several studies that have shown this is also not true. And pregnancy for scoliosis patients, I think it should be, as far as they have a good lung function, it's okay.
I'd like to thank you for a wonderful question. I just want to ask this from the surgeon point of view. When I was in Lyon, and of course we also take care for sagittal balance, especially in the older population. Usually we don't pay so much attention when we deal with the kids. But your statement was very meaningful when you says, okay, kids can compensate that. We see lots of kids with a head like that after that. And probably in the 30s or 40s they will have a problem. Do you now routinely use these measurements for getting the exact values of kyphosis and lordosis for each one that you perform, idiopathic scoliosis, the classical one, surgery with fusion?
Yeah. Whether we apply this thing and we measure all of them? Yes. Yes, we measure all of them. The problem with this is, as Maria has mentioned, so the PI is developed until age 18. So we don't have a very good data for kids, but we know that kids are more introverted than the adults. So we just do our calculations regarding that they have more introverted. But we definitely measure in all of them, and we bend the rod accordingly. But the problem is, it's not possible to get the kyphosis that you should get all the time. That's a big problem. So I don't know whether we should do an anterior surgery, cut the discs, maybe osteotomies, because the anterior part, as Maria has shown, is longer than the posterior part. So when you turn it, you try to create kyphosis, but it's really very difficult. But in some patients, we can do that, and we see immediate change in the cervical spine, and this shows that it's a good sign that we were able to get some nice correction. But we do routinely now for each and every patient. I think hopefully we will present our case series next year.
Imamo vremena još za jedno pitanje. Ima neko?